Can you tell me the first case of the TAVR treated with the CIT in France? But I know the first case of the valve in Germany. And what time? Can you tell me exact time for that case?
Yeah, so we started the journey in 2003, 2004, and we had the very first cases in our hospital here in Germany in 2004, 2005. Those were the first 25 patients that we treated together with our surgical colleagues. But it was not so easy in the very beginning, as you all know.
Yeah.
Many of our colleagues did not believe that this treatment would be possible. And so I think when you are convinced that some treatment is possible and you believe in this treatment, you just have to go and to work on it, regardless of what the community tells you and regardless of what whether they are upset with you. If you think this is the right thing to do, I think then you should proceed. And as we all know today, it is a convenience. Times have changed, and I am very happy. I remember my very, very first days in China when I came there, and we worked together basically in two spots in Beijing and in Shanghai. At that time, I was very happy, and I was also very proud because I believe that this less invasive treatment option would be very, very valuable for the large population of Chinese people, because your country is so big and your country is so rich in resources. We thought that this would be a very, very good thing for the Chinese population. And I have to also say that many of my surgical colleagues in China greeted me very friendly. They were very, very polite. Well, they were skeptical, but they were very, very polite, and they were much better, much more polite, and much more receptive than my German colleagues. I can tell you, when I presented the first data at the German Society meeting in 2004 or 5, I needed some help from the United States so they would not trash me and they would at least treat me politely because an American colleague was on my side and they had to be polite. Otherwise, they would have put me in the trash can and attacked me, and I would not be able to survive that. So we had some tough times, but it's very, very good that we reached the level and the standard of care that we have today.
Yeah, thank you. Thank you. Tell us about the story of the TAVR. So I think it's in the very earlier stage, and 20, maybe the 15 years ago. I think at that time it's really the tough. It's very hard time for you and for the pioneers. So because at the beginning the device is so big, so and also we don't know the morphology of the leaflets. So it's a lot for the complications. So it's really the hard time. But now everything is changed. So it's the TAVR, the technique is the widely used in the whole world. So in China now it's nearly 200 hospitals. The TAVR the technique has already used for the patients. I think it's the patient and all the young doctors should to make lot of thanks to you and the Grube in France. I think you are pioneer in this field. And so in the last several years, the indication of the TAVR, the middle and the low risk of the patient. So and now the guidelines also changed. So today we have some the questions because in China and still in the early stage, although we have already started about 8 years from 2012, but 2010 it's only 3 cases we use the cover device. But it's actually we will start the TAVR program in China from the 2012. So after now, it's already 8 years. So in China, it's nearly the 5,000 cases finished. But most of the cases finished by the local the products, for example, the Venus A, the VitaFlow, and so the both of the device get approval from China FDA. But the third device is called Fuwai. So maybe tomorrow evening, in Beijing time, tomorrow evening, I will present the data of Fuwai, the third device of the TAVR in China. I will present the data in PCR. So tomorrow evening I will present the data, all the data. So I think it's more and more the Chinese physicians and the cardiac surgeons are interested in the TAVR. And so I think it's a similar both the China and the Germany. So now it's about 30% of the operator are the cardiac surgeon, and 17 operator are the cardiologist. So I also know in Germany, and some cardiac surgeon also perform the TAVR the procedure. So yes. Yeah. So maybe now my colleague, Professor Yong, maybe they can ask you some questions.
Hi, how are you? A long time we didn't see you in China on COVID-19.
Yeah, but the flights are coming back now. I heard Lufthansa is having once a week a flight to Beijing and Shanghai.
Okay, hope we can see you maybe at the end of the
hopefully.
Yeah. So can you introduce, last year we have 2 great trials, presented in ACC about the partner 3 and Medtronic low risk. So after these 2 trials, what's the situation of TAVR in Germany? Do you think, it's really extended, to the low risk?
Yeah, so thank you. First of all, thank you very much for having me. It's always great to see friends in good spirits and in good health in these difficult times. So thank you for discussing with me some of the points that Professor Wu was mentioning. And most importantly, recently we had the low risk approval for the S3 and for the core valve Evolute platform. And I think the low risk situation is a logical consequence of going down the surgical risk spectrum from inoperable down to low risk. So we have reached a very important goal in the treatment options for patients with low surgical risk based on the randomized trial with the 2 devices. In addition, in Europe and in Germany, we have CE mark now for bicuspid application of the Evolut platform, which I think is very, very important because you have a lot of bicuspid, heavily calcified patients in China. The most severe that I have seen in my professional career when I traveled were cases in China. Heavily calcified, small annulus and bicuspid morphology. So you have taught the rest of the world a lot about bicuspid anatomies, and based on your expertise and your experience, we built our knowledge up to where we are now. Yesterday, I had a call from Brazil. They were asking me, a 81-year-old patient with bicuspid morphology, heavily calcified, what would you do? And let us not forget, the surgeons are not our enemies. The surgeons are our colleagues and our friends. And if there is a good patient for surgery in the bicuspid anatomy, I am still inclined to send this patient to surgery if the risk is low and if the result will be good. So this is a very important step, the low risk situation and the bicuspid approval based on what we learned from our Chinese colleagues. However, let me point out one thing that is, I think, very important. Many people are confusing and even confounding low risk with young age. You always hear, oh yeah, now we're going to lower risk patients, but they really mean we're going to younger age patients. And this is not the same. This is entirely different. And we have to, I think anyway, we have to be aware of the fact that younger age, and with younger age, I mean patients in their 60s or 50s, we have to look at TAVR differently than in patients above 75 for reasons that you all know, but that is a different story. Also, let us not forget the low-risk trials, TAVR trials, both for Evolut and for S3, including patients in favor of TAVR morphology and anatomy. So patients with severe coronary disease, patients with bad access, the whole bicuspid morphology, they were all excluded. So let us not forget, when we talk about low risk, the patients that were included in these trials were favorable for TAVR. This is a different story if you have patients with coronary heart disease, with bicuspid morphology, with bad access in the peripheral. So we have to be a little bit careful to say now TAVR is open for everyone. I don't think that we are there yet.
So I totally agree with you what you have said. So I think it's for the patient with a low risk of cardiac surgery, but it's not low risk for TAVR because of morphology. And yeah.
Yeah, as you mentioned about the age, you mean low risk it doesn't mean younger age. So what's the limit of age if you recommend the patient to TAVR or to steroid? So you think maybe 60 years old or even younger, or yeah?
Well, obviously, younger age in our world with heart disease is very arbitrary. You cannot say 70 up and 70 down because, as you know, there are very old 70s and there are very young 70s. So it's also the biological age. What I really mean, and we in Germany anyway, we are doing the cutoff between 70 and 75. Between 70 and 75, we are discussing the cases regularly with the surgeons, so the patient has the options to go either way. Above 75, patients, the majority of patients go into the TAVR program, unless they have some prohibitive risk for TAVR. Then surgery is an option. But 75 up goes to TAVR. Between 70 and 75, we discuss with the surgeons, and below 70, we have to be very careful. This is also discussed with the surgeons, because remember when you have a patient, for example, with 65, then you know when he gets a TAVR valve, he will probably get a second TAVR valve during his lifetime.
Yeah.
And if you go younger even, he might actually have 2 TAVR valves depending on his age. So we have to be careful what we recommend at the very first step for those patients. Should it be a surgical valve, a bioprosthetic surgical valve, and then a TAVR valve followed by another TAVR valve, or should there be a TAVR valve followed by a TAVR valve and then surgery, but then you shift the risk to surgery for the older age. So this question has to be answered very carefully. And my personal opinion is, it's not a bad idea if you are, for example, 60 years old, 65 years old, and you have a bicuspid valve, to take the surgical option first, have the valve removed, put a biological valve in, and then follow the patient. If the valve degenerates, then the patient might be 75 or older, and then you put a TAVR valve in. The other thing, seriously, have to be considered the coronary access, because you have to have coronary access to the coronary arteries. When you're younger, chances that you develop coronary heart disease is high, and you cannot block the ostia of the coronaries by your TAVR device. Something that's very important, a consideration that has never been raised when we treated old patients or older patients. The other thing is, the questions of durability have not been answered yet. We have reasons to believe, good reasons to believe, that we are doing well with the TAVR valves compared to surgical valves, but we don't know yet when we look into the bicuspid anatomies, calcifications, when the valves are not really expanded well, whether the durabilities are the same as in surgery. So these questions have to be answered on top of the conduction disturbances, left bundle branch block, right bundle branch block. So many considerations come into the game, and as experienced operators like yourselves, but also responsible operators, we have to weigh what is best for an individual patient if he is below 75 or 70 years old. What are his best options? Remember, the low-risk data included patients with low surgical risk, but still in their 80s. So they never included patients with 70 years. So all these things we have to consider when we open the door for all patients, or believing that now with low risk being approved, we can do TAVR on every patient.
Yeah, thank you. I think, you mentioned about many areas regarding, the age, the deterioration of the valve and the reaccess from the coronary disease. I think we should take care of many issues before we make a decision. Thank you. Thank you very much.
Yeah. Okay, so continue with this question. So, and I think it's the earliest stage. It's many years ago when you start the new technique, the TAVR, and the 15 years ago when you start the TAVR program. So the cardiac surgeons are not always applied to you. But I wonder now because now we have more and more the evidence and the indication for TAVR more for the low risk. So I wonder, so in a hospital in Germany, and cardiac surgeon and should be applied to you now. It's not because before it's not very applied. But now I think now it should be cooperative because they are already realized that the TAVR technique is successful for the most of the patients. So I wonder, so if the cardiac surgeon they have the patient with the low risk, for example, the 70 years old. So and they want to transfer the patient to you or not, because now we have more evidence.
It's a very, very good question because it affects the young generation of cardiovascular surgeons. How are they gaining experience in, these severe aortic stenosis patients? It is a very crucial question because, if you do not operate on these patients anymore, you don't have experience. So I think when you talk about severe and high-risk patients, the situation for surgeons is a little bit easier. When we talk about low-risk patients, then it becomes a little bit easier because it depends basically on your heart team situation locally. You have very experienced operators, you have good operators, you have good surgeons, you have mediocre operators and mediocre surgeons. So we are not all created equal. So there are differences, obviously, and it is very important that you are aligned with your surgical colleagues when you talk about low-risk patients, because obviously it would be a good patient for TAVR, but it would also be a good patient for surgery. And I think if the results are the same, let us assume the results of both treatment arms are the same, the patient will always prefer the less invasive approach. I think it is a fair statement when we say that. Nobody would like to be cut open. Many surgeons do minimal invasive now with a small cut. So there are viable alternatives to TAVR in the United States. For example, they are excellent, and here too, and I'm sure in China, they do not cut the complete sternum open. They do mid-sternal cap, or they do minimal invasive on the side. So there are various options, and then it depends on the morphology whether we are successful or whether we are not successful. It really depends on the individual cases. Here at our hospital, in our institutions, in general, the low-risk patients are going now with higher age. They go, which is 75 up, low risk, they go to TAVR. If they are below 75, then it is going to be a discussion on the individual basis together with the surgeons. And then it is being decided, depending on the morphology, this goes to surgery and that goes to TAVR. The patient being included in this decision-making process. The patient has to know the advantages of a good surgical procedure and the advantages of a TAVR procedure. That is, I think, an important issue when you talk to the patients.
Yeah, thank you very much. So I totally agree. So and because it's recently, so we have more and more the TAVR procedure. So I mean, sure. So not every patient with the high risk or the low risk for the cardiac surgery is the suitable for TAVR. So we should select the strategy depends on the morphology of the the aortic root. For example, it's very, very severe calcification. It's difficult to open by balloon. I think it's not very suitable for TAVR because the cover or other devices is can't totally open. So I think it's long-term outcome not good. I think maybe we can come to the coronary intervention area. So because now if I have a patient with the coronary heart disease, so maybe the first we can calculate the syntax score, but we also seriously consider the morphology of disease. If, for example, the left main, the bifurcation, and very, very calcification, and also the cardiac functions, the severe impaired. So maybe the first I choose the bypass, and but on the other side is the patient with the left main bifurcation, but it's the morphology looks nice. Maybe I can select the PCI. I think in the future, and with the improvement of skill and also the advance in the design of new devices, I'm sure so both TAVR and TAVR can be selected for the patient with low risk. But for the operator, if you select the strategy, and which depends on the morphology. Yeah, I totally agree with you. Maybe for the next, yeah.
Absolutely. I think you're hitting it on the point. It depends individually how extensive the coronary heart disease is. I think it is very reasonable to say that if you can resolve it by a percutaneous procedure fairly quickly without additional risk, it is fair to say we can do it that way. But I think you're totally right. When it is a more complex situation, then I think a bypass surgery together with a device with a replacement is a very, very good option. At the end of the day, we want to treat the patient. We don't want to put flags up. This is what we did. This is what we did. We have to do what's best for the patient. And I think you were totally right when you described the complexity of the coronary morphology as being the most important decision maker for either going percutaneously or going surgically.
So as another question, so the reply I think over and over. So because for the patient with the low, very low coronary, and for example the height, the coronary osteo to the annular level is less than 10, and so according to the CT analysis, so very, very high possibility to be included after TAVR. So, and I wonder, so what's your strategy? So do you want to continue TAVR with the left main protection, or you transfer to the cardiac surgery. Because if you protect with the stent in the left main, so after TAVR, I'm afraid, so the stent in the left main will be the problem in the future. Yeah. So so recently I have some cases, and first, so because from the CT scanning, I think it's a very high possibility to be included. And so the first I test with the pre dilation with the balloon, and
Exactly.
we will see, it's possible or not. If it's after the ballooning, so it's totally occluded, so maybe I can stop the procedure. I transfer to the cardiac surgery, and otherwise, so I will continue the TAVR procedure. And I wonder, what's your opinion?
Thank you for the question. I think it is a very important issue that you're raising. The low takeoff of the coronaries always carries a risk of occlusion. And if you have an occlusion, it is a disaster. You know, the patient might actually die. The protection that you are referring to by a wire together with a stent is something that you might consider. Personally, to be honest, I don't think it is a very good option, because if you have a patient at risk, given all our criteria, a small sinus, a small root, depending on the prosthesis, on the TAVR prosthesis, and you have a risk of coronary occlusion, I would seriously consider a surgical proceed instead of a TAVR proceed, even though you can protect. You can protect with a wire and a stent. The publications show that the wire alone is not enough. You have to put the stent in, and if the coronary is closed, you can put the stent back, and then you trumpet it. You do the snorkel technique for the stent. But let us not forget, this is a bailout situation. This is something that you might be doing when the occlusion is occurring. This is not good as a selective procedure. Yeah. So I would much rather than doing a snorkel technique, I would probably consider surgery in high-risk patients, knowing that once you go in with when the patient has to come back for coronary disease or for restenosis, it is very, very, very difficult to get through the struts into the snorkel. And I consider these procedures, the wire and the snorkel, as a bailout procedure, and I would only use it if there's no other option for that particular patient, because the long-term situation with snorkel is not very good. Even with basilica and all of these other things that you might consider later, I think when we have a chance to decide which way to go, we should be in favor of the patient and go then for a surgical procedure instead of risking an obstruction with maybe difficult follow-up problems in the intermediate or long run.
Yeah, thank you. So, Professor Yang and do you have some questions? Because this, I think now it's a very good time to interview, to talk with the Professor Grube, because so I think among all the meetings, so the meeting for today is especially because we can talk each other the face to face. Yeah.
Good morning, Professor.
Good morning.
We also have a question about the partner 3 trial, because as we know,
which one?
Partner 3 trial.
Partner 3, yeah.
Yeah, and we can see that from the first year follow-up, the TAVR group has much better results than the TAVR group on death, stroke, and rehospitalization. But at the 2 years follow-up result, we can see there is a trend that the TAVR group catch up the TAVR group, especially in death and the stroke. And we learn from the result, maybe there is 3 reasons, and one is the TAVR group has higher mild PVL and also have a higher rate of the subclinical valve thrombosis, and also maybe the TAVR group have lower concomitant procedure than TAVR group. So do you think there is the time that we can use a more aggressive therapy, just like anticoagulation therapy in the future, and also we can do more concomitant procedures such like the one-stage PCI and TAVR in the future to adjust this situation? Thank you.
Yeah, I think you're raising a very important point. Obviously, when the 2 curves of the S3 trial, when they were coming together again, and it is a good example on how that we cannot only look at the intermediate at the short term, but we have to look at the long run. And we see that's why these trials are so very important. And also, if you look at the S3 results with degeneration, which is quite different from other trials, so this is not the class effect. So unfortunately, my feeling is that given the fact that S3 the study is done with S3, we can only talk about this being the S3 situation and not in general the situation for Evolut, for Lotus, for Symetis or other valves. So we have to be very careful, but I think overall the situation is favorable. We have to see what the long-term results show, whether the curves are going parallel now from now on, or whether the curves even cross and we have more difficulties or even better situations with TAVR. Time will tell. We have to follow these patients, as you know now, for 5 or even better 10 years. But in the meantime, we have to make decisions. And we cannot wait until we have a result in 5 years. So time will tell us in the future what is the best way to go. But I think it raises a flag that we cannot take things for granted, that we have to look at these patients, number one, that we have to have a long follow-up before we make any definitive decisions, and also that we look individually at certain valves and not say this is a general statement for all valves. So I think in that regard, it is very important that we differentiate S3 from other low-risk trials.
Okay, we'll come back.
Before the connection breaks down, it was very, very good to see you. It was excellent to see you in good spirits and good health. And hopefully we will see each other soon again, person to person, so that we can talk and exchange our opinions face to face